Okay, so this review is going to contain the last chapters of COAG from chapters 43 to 47. So chapter 43 here is on thrombocytopenia and thrombocytosis. So mucocutaneous bleeding is a word that we hear a lot with different coagulation disorders and platelet disorders. It basically refers to more surface bleeding, so from the mucous membrane, skin, and so on. And this is usually due to a problem with the platelets. Either it's a quantitative problem in which we don't have enough, or it's a qualitative problem, meaning the platelets aren't functioning right. So symptoms of cutaneous bleeding would be petechiae, purpura, ecchymoses, epistasis, and gingival bleeding. And I know I probably didn't say it right. Deep tissue bleeding is usually due to a clotting factor deficiency. So that would be kind of one of our hemophilias, for example, in which we're missing a coagulation factor. So looking at these terms real quick that we just went through, petechiae are small pinpoint hemorrhages, usually about 3 millimeters in diameter. Purpura are a little bit larger than that. They're little small hemorrhages, but they're about a centimeter in diameter. Ecchymoses is just referring to a bruise. Epistasis is referring to a nosebleed. So if we look here, we'll have a picture of the petechiae and purpura. So you can see it's just a difference in size. All right, so let's start with thrombocytopenia. The word itself just means a decrease in platelets, so we're going to be less than 150,000. It's the most common cause of why somebody might have bleeding. And again, it's due to decreased platelet production, or your platelets are getting destroyed, or they're just not getting distributed correctly. So let's first start with our decreased platelet production. This could be due to megakaryocyte hypoplasia in the bone marrow, so there's just not enough megakaryocytes to make platelets, or ineffective thrombopoiesis, in which we're just not able to produce and differentiate the platelet line properly. Congenital hypoplasia is referring to the lack of bone marrow megakaryocytes. Examples of this would be Fanconi anemia and May-Hagelin anomaly. Other examples here are seen. You can skim through them. I wouldn't worry about concentrating too much on those. Neonatal hypoplasia is involving a cytomegalovirus infection, toxoplasmosis, rubella, HIV. So it's involving an infection of some sort that also puts them into a thrombocytopenia. Other conditions could be due to different drugs that somebody would take, viruses, bacterial infections. So now looking at what increased platelet destruction are, so our platelets are getting destroyed before they should. And other main causes would be mechanical damage or consumption, or an immunologic response. So the first one here is really important. You definitely should know this disease is called immune or idiopathic thrombocytopenic purpura, ITP for short. The term idiopathic, again, refers to that it's unknown. So we're not sure why this might occur. There's some philosophies, but, not exactly known. Acute ITP is primarily seen in children. So you're going to see onset of bruising, petechiae, and nosebleeds. A lot of times it's linked to after an infection has occurred in that child. So, for example, if they just suffered chicken pox and then a little while later they have this ITP result. So it has been linked with infections in children. Chronic ITP can be found at any age, not just children. And again, the same kind of symptoms with the mucocutaneous bleeding, nosebleeds, bruising, and so on. So let's keep going. So let's look at our slide of ITP. If you look here, you don't see any platelets, right? You see just one over here, and it's quite a large platelet, so it's pretty abnormal. We don't want to see giant platelets like that. But otherwise, we're not seeing any other platelets in this picture. So that is showing a thrombocytopenia. All right, so drug-induced thrombocytopenia can be due to different types of drugs, such as penicillin and quinine. And we're just moving along here. We also have procainamide that has been linked with thrombocytopenia, and then heparin. Heparin is probably the most common one we hear about. When somebody is on heparin therapy, a side effect of that is having thrombocytopenia. So we would just want to make sure that we are monitoring their platelet counts. Thrombotic thrombocytopenic purpura, TTP, we first talked about this as part of MAHA, so the microangiopathic hemolytic anemia group. Again, that group is one in which you have the small Fibrin deposits or clots in the small blood vessels, and so it kind of shreds the blood as it goes through there. That's why it's a hemolytic process. Also, those little small clots are using up our platelets inside of them, and that's why we see the thrombocytopenia, the low platelet number, because they're getting used up. Along with TTP, besides the thrombocytopenia in the hemolytic process, there's some neurologic abnormalities, and there's also renal failure. So with this, we are going to see D-dimer tests, DTT, PT, fibrinogen, all are normal, and that will help us differentiate this one from DIC, which we've talked about before, in which in DIC, all of those test results are affected. So looking at a picture here, here's a picture of TTP, the MAHA. You're going to see, here you can see some target cells. The arrows are pointing to some schistocytes because of the hemolytic process, the shredding of the cells. Keratocytes or helmet cells are also another common finding. Hemolytic uremic syndrome is another type of MAHA. In this one, it's very closely resembling TTP, except for the renal disease is much more severe. It's been linked with E. coli O157 or Shigella, very bloody diarrhea, renal failure, thrombocytopenia, and it's found a lot in children. So the key difference there between HUS and TTP was that severe renal failure in HUS. DIC, we covered this in a chapter, but it is another type of MAHA in which you definitely have thrombocytopenia occurring, but you also have abnormal PT, PTT, fibrinogen, and a positive D-dimer. All right, increased platelet destruction due to disorders related to distribution. So normally your spleen will hold or store about a third of your total platelets. If you can see a thrombocytopenia occur if somebody has a splenomegaly, there's lots of conditions in which we could see an enlarged spleen, and all of a sudden now they're storing a lot more than they used to. So that could result in a thrombocytopenia. So that would refer to a disorder resulting in different distribution of platelets than normal. Thrombocytosis deals with an increased platelet count. We can see thrombocytosis with those myeloproliferative disorders. So the good example there was essential thrombocythemia, where it was extremely high platelet count. Polycythemia vera had a high platelet count. So there's several, and so on. So myeloproliferative disorders definitely have high platelet counts. Also, we can see them sometimes occur with other conditions and inflammation as well. Secondary thrombocytosis is a picture here. So you can see all those platelets there showing an elevated platelet count. Another condition that we didn't really talk about that would give a thrombocytosis is if somebody had a splenectomy. In other words, where they had their spleen removed, all of a sudden that third of platelets that were found there are now floating free in the blood and raising your platelet counts. All right, so that's chapter 43. We are now going to switch to chapter 44. So it'll take just 1 second here for it to switch over. And this is on qualitative disorders of platelets. So, and if you give me just 1 second. All right, so now my slide has come up. So qualitative platelet disorders, excessive bruising, mucocutaneous bleeding, and prolonged bleeding time. So with this, there's something wrong in the way that the platelet functions. We have a normal platelet count, but the platelet function isn't occurring correctly. So we can have either abnormal adhesion, abnormal aggregation, or abnormal secretion of the granule contents. One of these will be a qualitative platelet disorder. So first we're going to start with the disorders of adhesion. Bernard-Soulier syndrome is an example of a disorder of adhesion. Within Bernard-Soulier, we have the inability of platelets to bind von Willebrand factor. As a result, they're not going to be able to adhere or stick together. Von Willebrand factor, one of its main functions is platelet adhesion. Well, if these platelets are missing this glycoprotein 1B95, they're not going to be able to bind that von Willebrand factor in order for the platelets to be able to adhere or stick together. So please remember that. Let's look at some lab findings for Bernard-Soulier. Well, we'll see giant platelets, prolonged bleeding time because the platelet function is not performing right. Thrombocytopenia is seen with this, so a low platelet count, decreased platelet survival, normal aggregation responses to ADP, epinephrine, collagen, and arachidonic acid. but it does not have a response to ristocetin. So these agents are things that we can add in the lab to test how platelets are functioning when we add these different aggregating agents. With most of these in Bernard Soulier, it's fine, but because ristocetin tests to see if a platelet can adhere or stick, we're not going to see response here because we're missing the von Willebrand factor binding. So that's important to take note of for Bernard Soulier. And the next slide is a picture of Bernard Soulier showing 3 giant platelets that are found in it. All right, another disorder of adhesion is Glanzmann thrombocythemia. In this case, we have an abnormality in glycoprotein 2b3a. This glycoprotein 2b3a is where fibrinogen would bind. Fibrinogen has a role in platelets in aggregation or the clumping of platelets. If it doesn't have this glycoprotein receptor available, it can't bind fibrinogen to have the platelet aggregation occur. So without that, we see that we can't have a plug formation and serious bleeding will occur. So let's look at some lab results for Glanzmann thrombocythemia. We have a normal platelet count and normal morphology, so no giant platelets here, a very prolonged bleeding time because the platelets don't function right, abnormal clot retraction, lack of platelet aggregation to ADP, collagen, thrombin, and epinephrine, but the ristocetin is normal because it's not the von Willebrand factor here that's at a problem. That's fine. But the others are lacking. So make sure that you're going to be able to tell the difference between Bernard Soulier and Glanzmann thrombocythemia. They're very similar in that, but there's a few key differences in their test results. In Bernard Soulier, we saw thrombocytopenia, giant platelets, abnormal ristocetin, and it all dealt with that glycoprotein 1b95. In Glanzmann, we see normal platelet count morphology, abnormal clot retraction, and a lack of response to the ADP, collagen, thrombin, and epinephrine, all due to the missing glycoprotein 2b3a. So be sure that you can differentiate between the two of those on case study-like questions. Talking about disorders of secretion, this is going to be where we see granule deficiencies. Your dense granules contain serotonin, calcium, ADP, which helps with different platelet activation, aggregation, and so on. With this dense granule deficiency, it's just not going to be able to pack what it should into these dense granules. So it will affect, the platelet aggregation test. And we can see these in a couple other disorders, one of which that we haven't talked about really is Wiskott-Aldrich, which is severe eczema, recurrent infections, and life-threatening thrombocytopenia. For the alpha granule deficiency, otherwise known as a gray platelet syndrome, the alpha granules normally contain fibrinogen, platelet factor 4, von Willebrand factor. If you are missing these alpha granules and you cannot contain these things, you're going to see prolonged bleeding time, thrombocytopenia. The platelets have a gray appearance when they're missing those granules, so that's the reason it's called the gray platelet syndrome. And again, an abnormal platelet aggregation response. So the next slide just is going to show a picture of the gray platelets. It's hard to see. It's a little dark. But if you look here, here's an example of a platelet. Just kind of looks like a blah, little something on the background. All right, disorders that affect platelet function. Again, those myeloproliferative disorders, we will see some platelet function abnormalities occurring there. Also in multiple myeloma and Waldenström macroglobulinemia. In the vascular disorders, we see this hereditary hemorrhagic telangiectasia. I know I don't say that very well, but anyway, with vascular disorders, it's all about the blood vessels that are abnormal. And blood vessels have a role in clotting. And when they're abnormal, we do have a tendency then to bleed as a result. So we will see very thin-walled blood vessels in this disease. Epistasis is a very common finding among it. In acquired vascular disorders, there's one called Henoch-Schönlein purpura. So it's an autoimmune kind of injury seen in children, a lot of times following an upper respiratory infection. And the last one is amyloidosis. I'm not going to focus on this, but it is there for your review. So within this chapter of disorders that we just went through, make sure you definitely know the Bernard Soulier, the Glanzmann thrombocythemia. Those are quite important and their disease results. Let's keep going to our next chapter then. All right, Chapter 45 is on the lab evaluation of hemostasis. Um, just quick notes on specimen collection. We should know by now that we're collecting it in a light blue sodium citrate tube. That 9-to-1 blood to anticoagulant ratio is critical. If you don't get the full amount, then you're considered a short draw and we would throw it away. All right, order of draw, it should be the first tube collected, or it can be collected after a non-additive tube as well, but it should be right up there in the very first tube. Hemolyzed sample cannot be used on most analyzers. They have now come out with an analyzer that's more mechanical that you can use hemolyzed samples on, but a lot of places still don't allow them. All right, long-term storage, you need to remove the plasma, freeze it for a couple weeks if you want to do that. Just a note here, aspirin does definitely affect our platelet functions. So if somebody's on aspirin, that will prolong their bleeding time tests. All right, so I'm just going to skip through here. I don't think there's a lot I want to talk about. Bleeding time is there. That was something we've kind of done in lab. Just so you know that bleeding time is all about functioning the platelet function test. This is going to talk about the platelet aggregometry, is focusing on those reagents that you can add to the tubes and just kind of how they use it and go through it. So it talks about thrombin, ADP, so how they use it to test for it. So it's good extra information if that part was confusing you. There's the ristocetin, which has, if you ever want to remember, just link ristocetin with von Willebrand factor. And then the last slide talks about INR. When you guys are out in your practicum, you very much did a lot with reporting out PT results in an INR value with those. INR values are used to help monitor people's therapy, a lot of times the Coumadin warfarin therapy, and physicians are looking to see that INR in a certain range to know that they're getting the right amount of therapy that they should be. So it's a calculation, and it's shown here, the PT patient divided by the mean of the normal PT to the ISI, which is something we get from the manufacturer. Okay, so we are going to skip to our next chapter, which is on monitoring anticoagulant therapy, chapter 46. First one is that warfarin Coumadin. Again, remember, this is a vitamin K antagonist. So in other words, when somebody takes this, the way that it thins their blood is that it will go and make it so that the factors that are vitamin K dependent basically aren't going to be able to work because it goes and suppresses vitamin K. So those factors that need vitamin K aren't going to be able to use it. So then we can't go through our clotting pathways. So that's how it can thin the blood. So remember, the factors that are vitamin K is the prothrombin group, which is factors 2, 7, 9, and 10. So a lot of people take warfarin Coumadin to help prevent strokes, thrombosis, DVT, pulmonary embolism, and so on. Again, we use the PT test to help monitor the Coumadin along with reporting out that INR. So the INR they're typically looking for is anywhere 2 to 3 or 2.5 to 3.5. Most of the time, we would see a greater than 4 or greater than 5 INR as a critical value in which the patient now is at risk of hemorrhaging or bleeding because their blood is too thin. And then heparin therapy is commonly monitored by PTT test. All right, and then let's move to our very last chapter, which is chapter 47 on coagulation instrumentation. So there's different types of instrumentation that can be used in coag, mechanical, photo-optical, nephelometric, and so on. So we're going to go through a little bit on these. Just a quick note on mechanical endpoint detection. The electromechanical clot detection basically uses one stationary probe, one moving probe. As the clot forms, if there's a fibrin strand that is found between the two probes, it'll stop the timer and we know a clot has occurred. A magnetic clot detection will have a steel ball that will kind of click back and forth in the bottom of the tube. As the ball slows down, we know that that clot is starting to form. A very common example of this machine would be Stago brand. It's a very up-and-coming coag analyzer that a lot of sites are switching to. The nice thing with this one is a hemolyzed sample can be used because it has nothing to do with the hemolyzed part. It's a pure mechanical type of principle. So it does save us from having to redraw those very tough patients. If you had a hemolyzed sample, you could still use it. All right. And this is just going to show that Sago principle with the ball going back and forth there. And the second that it begins to slow down because of a clot forming, it will stop the timer. A very common principle in the coag analyzers is going to be the photo-optical. This is one in which there's a light source that's passing through. That's why most of the time we cannot use hemolyzed samples. The minute that fibrin strands begin to form, it will scatter the light, and then the timer will be stopped. Nephelometric is all about scatter, so turbidity. So antigen antibody complexes will cause turbidity, which will scatter light. Chromogenic is about color formation. And immunologic is about another antigen antibody complex. It's very similar to nephelometry. In this one, they're looking for agglutination. They're using latex particles. Okay, so I just want to look. I think in your practicum, you saw different specimen things that would affect different instruments. So there's some specimen quality type flags at the end here that you can definitely read through. It just, again, depends on what type of analyzer you have and what kind of principle it is under. But that is the end of the last chapters of coagulation.